You are listening to the Aging Starts Now podcast, where it's all about responding with confidence to the legal, financial, and personal challenges created by a disability, unexpected illness, or aging in general. Join us weekly as elder law attorneys Barbara McGinnis and Chris Johnson, along with other members of the Johnson McGinnis Elder Care Law and Estate Planning team, talk about the tools, techniques, strategies, and services that will make the elder care journey easier for everyone involved. Get ready, because aging starts now.
Have you ever heard of palliative care? Do you know what it really means? If not, you're not alone. Many people aren't familiar with it. I'm Elder Care Coordinator Debra King, and on today's episode of Aging Starts Now, we're diving into what palliative care is, how it works, and how it's different from hospice care. Joining us is someone who knows this field inside and out, Shelby Kelley, who is a nurse practitioner of palliative care. Shelby, thanks for joining us today.
Thank you so much for having me.
Great. So to start off, let's talk a little bit about defining what palliative care is and how it's different from hospice care.
A general definition of palliative care is a medical specialty that for anybody that has a serious or life-limiting illness that wants to focus on quality of life and providing support and alleviation from symptoms.
Okay. Who would be a good candidate?
So there are multiple different ways to receive palliative care, whether that be in clinic palliative care, in home palliative care, even in hospital palliative care. And every company and clinic has their own set of criteria and policies and, subset of patients that they see. But in my experience, most candidates for palliative care have what, like we said, a life-limiting illness. So anything along the lines of congestive heart failure, COPD, dementia. There's a long list of those kind of disease processes, but also people that are experiencing a decline and have an estimated about less than 18-month prognosis. So people that we would not be surprised that if their disease continues to progress in the way that it has, that they may pass away in the next year and a half.
So a little longer window than hospice. That's one of the major differences.
Yes, that is definitely one of the major differences. In hospice, they consider that end-of-life care and actually have to have a determination from a doctor that they have a estimated less than 6-month prognosis for hospice.
Do you have to have a doctor's order for palliative care?
No, you do not. Where I specifically, in my experience, so people can actually self-refer to palliative care. They can reach out and, just self-refer them. All we have to have usually is a medical documentation. So clinic notes from primary care or recent hospitalization records. So we can overview diagnoses and kind of determine, on paper, are we showing that evidence of that less than 18-month prognosis and a palliative appropriate diagnosis?
Okay. Do I keep my own doctor, or is there a special doctor that does palliative care?
So usually in my experience, we provide in-home palliative care, and you usually get the same nurse practitioner that comes to see you about once a month with that service. Again, it's different kind of across the board depending on how you receive palliative care, but usually you will stay at least with your primary care physician. They're going to continue to manage your chronic health conditions like diabetes, hyperthyroidism, hypertension, just those chronic things that people struggle with in those medications. Because palliative is really in there for just additional symptom management, and they don't take over the management of those chronic conditions. And also, if someone, say, has cancer and they want to continue to see their oncologist and receive chemotherapy or radiation or any kind of aggressive treatment like dialysis, well, that is absolutely something you can continue on palliative care.
Okay, so I can continue to get treatment as opposed to hospice, where often those treatments have to end to be on hospice care. Does Medicare pay for palliative care or other insurances?
Yes. In most cases with traditional Medicare, there is no authorization or prior auth required to receive palliative care. Some of the Medicare Advantage plans, in my experience, do require an authorization request to be sent to them, but usually there's not much trouble getting that approved, those visits approved through those Advantage plans, as long as you have the appropriate documentation and can prove that it's medically necessary.
Okay. Okay. So, what kind of symptoms are managed under palliative care? You said palliative care manages symptoms where your physician is still managing your primary diagnosis. So, what would you help me with?
Any symptom related to that palliative diagnosis. So a lot of our COPD patients struggle significantly with shortness of breath. So there's different medications that we can trial to help with the alleviation of those symptoms. Pain is also a big one. So, cancer related pain is a significant thing that we try to help with, and any other pain that's related to their palliative diagnosis as well. We also provide, the treatment of acute illnesses too. So any kind of infection that you may experience, in the home, we try to catch those early and provide treatment for those in the home prior to them kind of getting out of control and, landing people in the hospital. One of our primary goals is, other than comfort, is to avoid hospitalizations as well.
And that's one of the things I've heard a lot about palliative care is clients can get the care in their home. They're not having to go to the doctor every time they're worried about something changing, or having to go as frequently for tests and things.
Right. While we still, require that relationship with primary care, a lot of times, because we do aim to be in the home at least once a month, because we are in there so often and are keeping, such close eyes and ears on the patient. The primary care may even reduce their visits to once or twice a year instead of patients going every couple of months, because they were having so many recurrent issues. So if we're better able to manage those symptoms and keep those close eyes on those patients and keep them out of the hospital and things like that, a lot of the time there is, a reduction in the amount of times that you're actually having to get out to go to those specialists and that primary care doctor as well.
Okay. Okay. So you're a nurse practitioner. So it sounds like you're in the homes seeing the patients. Who else is on your team?
So I am actually the director for my company, our branch right now. So I'm not in the field as often as I would like to be. I do more of the administrative stuff behind the scenes now, but my experience is in the field, providing direct care to patients. So while I'm the director, we do have a couple of support staff in the office as well, our palliative care coordinators, which we could absolutely not do our jobs without them. They are the real people in the office answering our phones and providing that direct point of contact for our patients. So when they do have any issues or any concerns, they can reach out directly to our office and talk to a real person and know that a nurse practitioner is going to call them back. And then we do have a team of nurse practitioners that, carry their own patient census. So you have a nurse practitioner that covers a specific territory. So depending on what city you live in, that's kind of how we divvy out patients to nurse practitioners, but that also ensures that continuity of care, that you get to build that relationship with that nurse practitioner. She gets to see how you are month over month and recognize that decline or changes in your health and kind of make recommendations from there. And then we obviously have medical directors, the doctors that kind of oversee everything for us, that we can contact if we have any questions.
Do you have like social workers and chaplains on your team like hospice does?
We do not. So we do not have any that belong directly to palliative care. However, we do borrow from our hospice partners from time to time. They are generous enough to loan them out to us if it's necessary.
What about if I needed like home health physical therapy? You said I could still get treatment in the home while I'm palliative care. Would your agency do that, or would someone else?
We do not provide that. No, we do have preferred home health partners that we can make referrals to and place those orders if we are in the home and think that you would benefit from physical or occupational therapy, or even skilled nursing services for wound care, or just even more assessment and observation than we're providing. Home health is usually in the home. It's more of a short-term option, but they're in the home more
Uh-huh.
often, usually weekly. But that is something that our nurse practitioners can order if necessary. And we have home health partners that we definitely enjoy working with because of that.
Okay. Okay. So you're taking care of the patient, you're seeing them once a month or more often as needed, keeping their symptoms managed, their pain, their breathing, dealing with acute illnesses. What about the family and the caregivers? How can you help them? How does palliative care help families and caregivers?
If the patient is open to us communicating with family members, we always try to keep everybody in the loop that they want in the loop. We obviously don't want to divulge any medical information that they don't want shared with anyone, but oftentimes our patients do require a higher level of care and caregiving, and they live with their family members, and the family members are heavily involved in their care. So we're there to treat the patient as a whole, and a lot of times that involves their caregiver, involving them in conversations, letting them know what we're seeing, and providing them guidance on how to manage this illness or what may be necessary, making sure that they have all the information about the medications and how to administer those. A lot of palliative care is education, not only for the patient but for the family as well.
Okay. Okay. So if the patient gets worse, there would be a determination to refer to hospice, or a discussion with the patient about when hospice becomes appropriate over palliative care?
So in my experience, I start hospice conversations on day one. So the moment I meet the patient, I obviously would introduce palliative care and our role within their home and their care. But obviously, if they qualify for palliative care, they have an illness that is likely progressive. So I like to start talking about that from the first moment to kind of get prepared. We start those goals of care discussions and that advanced care planning very early on, or at least we try to, so people can be prepared and have those discussions either with their families or whomever they want to have them with, and make sure that we have a plan in place for when that decline does eventually happen.
Mm-hmm.
So if we are in the home and we're recognizing this decline, or they have some kind of event and they are ready for hospice, medically, and then their goals align with that. They don't want to go back to the hospital, and their health continues to decline, and they need more support even beyond our once a month visits. Then we can help with that transition to hospice.
Okay. Okay. Would the converse be true? I've seen where having that regular routine care in the home and that attention that nurse can provide, they stabilize. Would they ever graduate off of palliative care for a while, or would they continue on that until hospice or the end of life was inevitable?
So if they ever reach a point, this is not super often, but I actually had this experience just last week with a patient who had, really gotten better. She had progressed in her illness instead of declining, and she was able to leave the home and go to church multiple times a week and attend, outside functions and go grocery shopping even. And while she still had a palliative appropriate diagnosis, I told her, I was like, I just don't think that you're sick enough for us right now. And she agreed. She said, I'm doing really well. I don't know that I need all the attention that you're giving me. So she was agreeable to discharge from our service. So we got to have a little graduation ceremony for her at our last visit. And she is a very special lady, and I will miss her. But she agreed with me. I don't think that she was quite needed us anymore. So you can absolutely graduate off of palliative care and hospice.
Oh, that's a wonderful, happy ending for someone that
Yes.
they did get better. So, anything else we need to know about palliative care to help our listeners?
I would say I think it's a very underutilized service, in large part because a lot of people don't know that it exists and they don't understand how it can be helpful. And I would also say that it's very misunderstood by a lot of primary cares and specialists too. When you mention the word palliative, I think they go straight to hospice, and something that I heard not too long ago that I really like to frame it to people is all hospice is palliative care, but not all palliative care is hospice. And I don't want that misconception to be out there that, palliative care means I'm dying. And that's not the case in a lot of scenarios. And it can be so helpful in managing those symptoms and keeping people out of the hospital and kind of delaying the progression of their disease process and really providing a lot of support and comfort to patients and families.
Awesome. Well, it certainly is needed in our communities. And I hope that listening to this podcast will get the word out. Share this with your friends. That's all we have time for today. I thank you, Shelby, for joining us. And thanks to our listeners for joining us on this episode of Aging Starts Now. If you know someone who could benefit from this conversation, we encourage you to share it with them. Johnson McGinnis Elder Care Law and Estate Planning is a life care planning law firm dedicated to helping individuals and families navigate the complex care, legal and financial challenges that come with aging and disability. Be sure to tune in next week for another episode of Aging Starts Now.
Thank you for listening to the Aging Starts Now podcast. For more information about today's show, visit tn-elderlaw.com, click on the Free Resources tab, and then click on Aging Starts Now. You'll find the show notes there. And while you're at it, why not check out all the free resources available at tn-elderlaw.com. Document downloads, the Johnson McGinnis blog, educational videos, informative articles, helpful links, a TV show, and more. It's all there, free for the taking. If you enjoy listening to the Aging Starts Now podcast, please subscribe, rate the show, or leave us a review. It's easy to do on whatever app you use to listen. We would love your feedback on the show. Aging Starts Now. We'll be back next week with more candid discussions about the challenges created by aging, disability, and unexpected illness.